Welcome to everybody who's joining us today. We will give it another minute or two to allow folks to join, and then we'll get started. So thank you for your patience. We'll give it another 30 seconds or so, and then we'll get going. Thanks to everybody who's joining us. Wonderful. So thank you to everyone who's joining. A good day to you. My name is Sarah Hess. I sit in Geneva in the World Health Organization within the Health Emergencies Program. It's my pleasure to moderate this WHO technical briefing on monkeypox with a specific focus on the transport and tourism sector. So today we have two presentations. We have with us Dr. Rosamond Lewis, who is the technical lead for monkeypox at WHO and a public health physician. We also have with us today Dr. Ninglan Wang, who is the unit head for border health and mass gatherings here within the Health Emergencies Program at WHO. Also on the line with us today, who will be able to answer questions and queries, is Andy Seal, who is a senior advisor in the HIV, hepatitis and STI department. And also we should be joined very soon by Victoria Willett, who is a specialist in infection prevention and control. So without further ado, I'm going to hand over to Rosamond first, who will give the first presentation. Just to say, we also have simultaneous interpretation into French. So if you are watching on Zoom, you can use the French channel, and please do put questions into the Q&A function, and we will have a time at the end to answer those questions. So over to you now, Rosamond. You're on mute.
Okay.
Voila.
Yeah, thanks. Too many things on my screen or not enough. I can't tell. Hi, everybody. So can you now see the screen, the slides as well?
Everything's perfect. Everything's clear. Yeah.
Okay. Thanks very much, Sarah. Hello, everyone. Welcome to this session, and hopefully we will keep the presentations as short as possible, and so we have lots of time for discussion and questions and discussion. So this is just a technical background, and I will focus on specific points in the slides. I won't necessarily go through every single point on the slide, but I believe the idea is that you also have these to consult with afterwards. So the main points on this slide is that the WHO Director General did declare monkeypox to be a public health emergency of international concern, and this was on the 23rd of July 2022, due to the unprecedented and rapid spread to many countries of monkeypox, which had previously been reported primarily in a few countries in West and Central Africa, with only very limited number, fewer than 10 exported cases in other countries. So this represented something new and different and a threat. And so this is why the public health emergency was declared. The third emergency committee meeting will be held in a few days' time, actually. So this is to give you an overview of where we are today. We have 106 member states who have already notified a confirmed case of monkeypox. WHO records information on confirmed and probable cases, of which over 68,000 so far, including 26 deaths. These numbers, of course, may be underestimates. There are concerns around access to testing. And of course, also concerns that some people individually have about going forward for testing. And so these all may represent a slight under notification of cases. However, as you can see, the European region was the first affected, starting in May, then Canada, then the United States of America, then the South America, Central and South America, and of course the other regions of the world that you can see on the map. The second region most affected is the region of the Americas. It now has the largest number of cases, about 2/3 of cases, approaching 3/4. And you see that overall globally, the outbreak is waning, but at the same time, some countries are still reporting new cases. So today, or in the last couple of days, the latest country to report for the first time is Egypt. Here you see what we call the EPI curves of each region, the 6 WHO regions. You can clearly see that the European region is on a downward trend, and the Americas region is also starting to take that corner. For some of the others, it's a bit harder to tell as the case counts are a bit more sporadic. What we see here is that of all the cases reported, 97% are among men, which is most unusual for an infectious disease outbreak. And this is the demographic curve that you see on the top right, which is the age and sex distribution of the confirmed cases. So you see the vast majority are in purple, and you see most of them are men aged 30 to 39, or more broadly 18 to 49. And of these who self-declare their sexual orientation and activities, 89% have self-identified as gay or bisexual men who have sex with men. This is important, obviously, for travel and tourism due to the fact that many of these people are, of course, able to travel and willing to do so, and have access to themed cruises and such activities that we have already discussed here at EPI-WIN. Of note, of course, is that of the persons who are infected with monkeypox, 47%, which is a very high number, are also infected with HIV, but in these cases, their infection is controlled. And there doesn't seem to be any particular risk of severe disease for persons just for having being HIV positive, because their disease is well controlled. That situation changes for individuals or in regions where HIV status is unknown or known but not controlled with medication, and that represents a much different risk in terms of progression to severe disease because of their compromised immune status. You'll see also that we have some health workers affected, quite a large number, over 400 reported now, many of these in the community as well, but some of them also through occupational health exposure, which we'll come to in a minute. And you also see the self-reports of mode of exposure is through sexual activity. On the bottom right, the demographic curve looks a bit different. This is from the African region, where monkeypox has always been reported in about 25 to 30% of the cases reported. A quarter to a third are among women, and that's the difference in the EPI curve that you see on the demographic curve that you see on the bottom. I think the clinical presentation everybody is familiar with now, so I won't go through this in detail, but classically it's monkeypox presents as fever, swollen lymph nodes, typical or atypical rash, which progress from little vesicles, blisters, progressing to firmer, larger lesions with pus in them, and sometimes then, and often then they crust and fall off. These lesions can present anywhere on the body, but typically involve the hands, face, feet, mouth, and genitals. But we are seeing new syndromes in this particular outbreak, which include inflammation of the rectum or proctitis, urethritis, and other medical problems and complications arising from this. You've seen that there have been some deaths reported. Some of these are in persons with immune compromise and others not, some of them due to a range of different issues. So whereas most people have not a severe presentation of monkeypox, some do progress to severe disease, and hence the concern around this global outbreak. So what are the modes of transmission? The knowledge of transmission is obviously evolving in an outbreak which is unprecedented, but it is well known that as we've illustrated in the data just shown, that sexual encounters are most commonly reported as the setting in which transmission of monkeypox may occur. And this can happen through face-to-face contact, skin-to-skin contact, That can include simple contact with lesions on the skin, anywhere on the body, but also includes contact with mucous membranes, which include the mouth, obviously, but also the vaginal area, rectal area, or through anal sex, which can also be a mode of transmission. Clearly, if you have lesions in your mouth, then you also have virus in your mouth, and so mouth to skin contact of any form is also a possibility and a risk factor. Pre-symptomatic or asymptomatic, so this means a transmission in people who don't have symptoms of any kind or who don't yet have symptoms of any kind, is something that has not been well described in the past. We are just beginning to see an emerging picture that this is maybe part of this outbreak, but more data is needed. Other ways in which people can acquire monkeypox is through the skin, as such as through tattoo parlors. We have seen a couple of outbreaks involving persons who've had tattoos or ear piercing as well. That's been described in Spain, and also health workers who acquire needle stick injuries on the job while trying to get a swab. And so it's important to know that in fact we should not be using needles to swab skin lesions. We should be, if you have health workers also in your entities and your conveyances, they need to be well trained on how to obtain a skin specimen if that's required for diagnosis. We're also concerned about congregate settings, health facilities, prisons, and densely populated areas. So these are things that you may be less concerned about, but something that you need to know. And we also looking for identification of settings that may be at risk. And so your support will greatly appreciated going forward if you can also let us know when you identify outbreaks, so that we can also learn with you and support you and act upon that. So I think we've already described the most at-risk populations, men age 18 to 49 actually, are disproportionately affected. And so I don't need to go through this, but one thing that important to mention was just the very last point, last 2 points, which is if anyone is immunocompromised, very important that they be aware of the risks of monkeypox because they would be at high risk for severe disease. And the same applies to members of a household of someone who has this illness, because they may also be exposed through regular household contact, through of course, person-to-person contact, hugging, kissing, and so on, or sexual activity, but also through possibly exposure to contaminated bed linen towels and such. So the WHO response has been, of course, ongoing since May, and even prior to that, we had a program already engaging with the countries that were affected by this particular infectious disease. And so our objectives of the global response right now are to stop the outbreak, to stop human-to-human transmission, to protect the vulnerable. And I didn't mention at the beginning, but this originally was a zoonotic disease, which means that it transmits from animals to people, which is now manifesting, of course, as a human-to-human spread. But at source, we would also aim to reduce animal-to-human transmission in this environment. So our strategic approach is to, EPI-WIN is part of this, to provide as much information as possible to those who need to know and want to know, to protect themselves and to protect others, that everybody is called to action to support this effort. So thank you very much for your interest in this webinar today. At the same time, there's a lot we don't know. And so it's very important for us to continue to work on collecting evidence on whatever area of work it may be. So for example, we had a conversation just like this one with association involving cruise liners recently, and following that discussion, it was agreed that they would undertake a survey. So if you're interested in also undertaking a survey of any kind in your settings, this will add to the knowledge base and really be helpful to us. And of course, we do everything to work towards equity, whether it be within a particular setting, within a country, within borders, or across borders, to reduce stigma and ensure that everyone has access to the same services. For vaccines, they are available in some places, as you know. They are recommended for persons at risk. They're recommended after exposure for persons who are in contact with someone who has monkeypox. And there is just now new information emerging on vaccine effectiveness. We had one study before that suggested for monkeypox, this vaccine, which remember was developed for smallpox preparedness, these are related diseases. So we thought from one single study that smallpox vaccine was 85% effective against monkeypox. Now we have our first emerging studies, one from Israel, which suggests a point estimate of 79% vaccine effectiveness, and one from the US, which is suggesting 93% vaccine effectiveness. These are studies which have inherent biases in them, but it is still comforting to see that they kind of fall around the same point estimate of 70 to 90%. So that's very reassuring so far, but it also means, like many other things, vaccines are not perfect. They are not 100% effective in preventing infection. And of course, it takes time for your body to mount an immune response. So it's critically important to remember that vaccines need to be administered several weeks before peak protection is expected, because they do not work overnight. Thank you. That's it. Over to you, Sarah.
Thank you very much, Rosamond. So again, a quick reminder to folks to insert their questions into the Q&A. I do see some coming in, and we'll get to those after the next presentation. So I'd now like to hand over to Dr. Ninglan Wang for her presentation. Ninglan, I do have your slides, so let me get them up for you now.
Thanks very much, Sarah. First and foremost, I really appreciate the participants and your interest and your time for joining this webinar. I see this is an excellent opportunity, and that we can brief you our recommendations, advice in relation to travel, what we know, what we do not know, and what are the implications on the travel, and vice versa. It's great to collect your thoughts and also your concerns and all your questions and so on. So really appreciate this platform and to have this webinar. So next slide, please. I will start actually my presentation with a few words on the international health regulations, because most of you, I believe you are working on the travel and transport sectors, or you are travelers or prospective travelers. So you might be aware of these international health regulations or already operated under these regulations. So this is our international legal instrument, which has been signed up by 196 member states, and the regulation have two dual purposes. On one hand is to prevent, protect against, the control, and provide a public health response to the international spread of diseases. On the other hand, the regulation also aim to avoid unnecessary interference with international traffic and the trade. So just wanted to highlight this. And in these regulations, there are 10 parts. So 3 parts are actually concerning the points of entry, the health measures, and the health documents in relation to the international travel. And there are also numerous requirements regarding countries' capacity buildings, obligations for convenience operators, operators of points of entry, and travelers, and so on, scattered in the various other parts of the international health regulations. So this is just want to give you a little bit the background. Next slide, please. In the health regulation, there are also requirements set up for, the mechanism of declaration of public health emergency of international concern, which now is the cases of this multi-country monkeypox outbreaks, and how that recommendation will come out. For the monkeypox, the current multi-country monkeypox outbreaks, there are a few recommendations coming out from the last EC, the Emergency Committee, as Rosamond just mentioned. So there are 2 recommendations related to international traffic, primarily about the suspect, probable, or confirmed cases. They should be placed under, their isolation, and also the contents should be subjected to the health monitoring, therefore should not travel until they are determined as no longer constituting public health risks. So there are a few exemptions. For instance, individuals that need to travel for urgent medical care. These people are basically under life-threatening situations. Well, context was the pre-departure arrangements agreed between the health authorities, between the departure and the destination countries. So the continuity of the health monitoring will not be disrupted. Similar to the cross-border workers who are really commuting very frequently between the borders, if there are context of cases, they can continue the routine daily activities, but in the conditions that the health monitoring between the departure and destination countries or communities are, arranged. And the other recommendation is establish the operational channels between health authority, transport authorities, and the convenience and at points of entry. So this I will touch upon in the slide later, because this is also a core capacity requirement and an IHR to ensure a multi-sectoral mechanism for contingency planning and response. So there are many actions that could facilitate the preparedness and response. For instance, the international contact tracing, health information sharing, based on the establishment of this mechanism. Then last but not least, I want to highlight that WHO advises against any additional general or targeted international travel-related measures for monkeypox, other than what we have just mentioned above. This means that no travel ban or the closure of the borders. So I just wanted to also to bring to your attention. Next slide, please. So in summary, we just wanted to put together the use of public health information and interventions, which will be very useful for the travelers, also including the employees or, in the travel, transport, tourism agency, because you interact very frequently with the travelers. So these are the information that we also wanted to share with you. Again, for the cases or the context of the cases is usually subjected to the isolation for cases and the health monitoring for the context, though the non-essential travel should be discouraged. And also other considerations, if you are confirmed the monkeypox cases, you may be subject to local health requirements, during the health, throughout the health continuum, the travel continuum. That means the isolation of cases, for instance, in the destination countries. And if you are a close contact, according to the WHO definition of contact, throughout the travel continuum, you also may be subject to the local health requirements that implies the supervised or self-monitoring. And bear in mind to seek medical care if you believe you have been in contact with a case, monkeypox case, or suspect you may be developing the symptoms of monkeypox, and self-isolate or get tested if symptoms develop. And also, in order to really to make an informed decision, you need to be really aware of the risks of monkeypox, modes of transmissions, what are the compatible signs and symptoms, and what could be the precautionary measures. You protect yourself and protect the others from being affected as well. And get vaccinated if you believe you are at high risk and if the vaccine is available to you. We're in the context of limited vaccine supply, but there is a national policy that you can refer to in terms of what are the eligible groups, which are at high risk groups that also I think laid out in Rosamund's presentation. And then another point, which is also important to mention, is that the quarantine or exclusion from work is not necessary for the contact during the 21-day monitoring period, as long as no symptoms develop. But the contact should bear in mind to rigorously practicing the hand hygiene, respiratory hygiene, and avoid the sex during the this monitoring period and so on. So next slide, please. So there are lots of information resources that you can benefit from the WHO's website. So here I just put the link here. So you will see the graphics, the videos and the pamphlets, which could facilitate your risk communication efforts, either for yourself, for your family, for your networks. If you are also organizing for instance, seeing the cruises, seeing the gatherings and so on, and also for the general health information campaign. So that's are the resources that you definitely can capitalize on. Next slide, please. as we just touched upon in the very beginning, in terms of the recommendation on, to cement the collaboration between the health authorities and the different stakeholders at points of entry, the travel, transport sectors, convenience, the tourism sectors, and so on. I think that's very important because under international health regulations, there is a country capacity requirement in this regard. So the health emergency plan, which should be built on the multi-sectoral approach, is required for each point of entry, which means that the stakeholders, again, the POE operators, the convenience operators, and the concerned stakeholders, including the law enforcement agencies stationed at the points of entry, all this and the travelers and the employees and so on, they need to have the access to the information and also instructions related to the monkeypox. Again, as the previous slides outlined, all these general public health informations, which could be very helpful for the individuals and, to make informed, risk-informed decision about their actions. And then make operational arrangements and to facilitate the compliance with such requirements. So we know that, again, under the international health regulations, there are multiple health documents and to facilitate this type of information exchange and communication between the health authorities and other stakeholders and travelers. So just wanted to highlight the Maritime Declaration of Health and health part of the aircraft general declarations, which normally should be filled by the conveyances, the ships and aircraft, the masters, before and the forms need to be handed over to the public health authorities, the port health authorities on arrival. So these are the forms contain a set of the public health questions related to, what are the health status on board, whether do you have the cases detected or suspected cases detected. So these are very useful information to facilitate the health authorities to make their risk assessment. Next slide, please. Moving on to the international contact tracing. So this is our public health interventions that we usually conduct when this relates to the cross-border travel. So when we do the international contact tracing, so if there is a cluster or chain of monkeypox transmission involves more than one country, so typically when a case is identified on board, the conveyance could be the ships, a train, cross-border train, aircraft, or at points of entry, or returning travelers. And if there is something happens, and when they seek the medical care, brief their medical practitioner with a history of travel, so that could trigger international contact tracing. And how to do it? There is again the RHR. There is a defined, the communication channel to facilitate the cross-border, the international contact tracing. So the national RHR focal points is normally the focal points to operate this, to facilitate this practice. Who may be considered? So there are different scenarios. So we'll just make some examples and to, hopefully that could be, a little bit instructive. So if a probable or confirmed cases is reported in the conveyance, and so that really require case-by-case assessment and based on the context, based on the, context of that cases detected. For instance, in the aviation sector, there is a very well established and very well, let's say, the practice, a very well established practice for the cabin crew to manage the onboard potential infectious disease cases. And then for monkeypox, there has almost of the transmission, which includes potential transmission routes for respiratory droplets. And so there, the cabin crew is very well conversant with the practice if for the potential respiratory diseases on board. So that could be the contacts could be identified as people, the travelers sitting 2 rows before or 2 rows behind or at the same row of the potential case. However, this really need to be looked into the details because, as we say, there are sometimes on board there are some public health social measures, for instance, the masking and the physical distancing because of the COVID. So we need to know more, more details, whether these are the measures on board at the time the cases is also flying on board, and whether there is a skin lesions when the cases are detected on board and so on. So this really requires a collaboration between the convenience operator and the public health authority. So this is just an example. And then if for a confirmed case is reported in the destination country, then the local contact tracing guidance may be followed as well. And other considerations, this is always a big, the question mark or the big caveat in terms of data protection. So the international contact tracing between the national focal points, this is absolutely are very well regulated practice in order to make sure the confidentiality of the information. And then for monkeypox, there is some specificity in terms of the contact tracing because the cases may be hesitant to share details of their contacts. So they should be encouraged to directly notify their contact, which is based on experiences for HIV and the sexually transmitted infectious disease and so on. Next slide, please. Now, I will spend a few minutes on this, public health advice for cruise travel on themed voyage, as we have already had some EPI-WIN session on this specific setting. So I just wanted to highlight a few, principles here. First, we want to mention that there is a heightened risk if they're on the themed voyage, of course, based on the, the assessment for each themed voyage and looking at the voyage theme, passenger profile, and the nature of the activities. Knowing that the cruise ship themed voyage may involve the multiple and extended close interaction among people because the cruise normally lasting for 1 week or several weeks. And then it involves the aggregation of travelers from multiple countries of a region, and also the interaction between the onboard travelers and with the local communities when the ship calls at different ports along the sailing routes. And there, of course, onboard entertainment venues, activities, which might present prolonged close contacts and high-risk activities such as sexual activities with multiple individuals and so on, and other themed cruise LGBT. So there could be the conducive environment for facilitating the transmission for monkeypox. Therefore, we wanted to, just give a little bit more focus on this specific setting. Next slide, please. And in the event of a probable or confirmed case of monkeypox on board, there are some risk mitigation measures. Before getting into the details of what I wanted to also to highlight is the cruise ships, are operating engaged international travel, so they're subject to also the health requirements set out and the international health regulations. So when the ship calls at different ports, they need to submit to the health authorities on the maritime health declaration form, and also the ship sanitation certificate, which will review the health status on board, and then the port health authorities were also based on the information to decide whether they will go on board to have further inspection or to support the public health action needed. If there's anything happened on board. So there, normally the cruise ships, they do have a very good outbreak preparedness and response mechanism, and also the contingency plan. So here, just highlight a few elements that very, linked to the monkeypox, the disease nature. So there increase the daily cleaning and disinfection frequencies, particularly for the laundries, and so the laundry room and so on, and also the crew who will be dealing with the laundry. So you need to have the health educations, and in case of there's a monkeypox case detected on board, how to increasing the frequencies and also the to make sure you have these surge capacities, and then apply precautions at the ship medical facilities. And so the medical doctor on board need to be aware of the risks and the treatment, and also the precautionary measures, and to provide it to the travelers on board. And then modify the high risk activities and so on, and conduct the contact tracing, and very important, if needed, to delay the embarkation to allow sufficient time to conduct the cleaning and disinfection activities between the cruises. So the one cruise would not become a source of the outbreak of the next cruises. So this is also important to bear in mind. And then also the communication plan, if there are cases on board is detected, so this specific communication plan needs to be triggered, which means that the ship needs to provide regular updates in terms of what health measures have been implemented on board, and to the next port of call, the public health authorities, and alert the passengers, the staff, what they need to do, and notify the new passengers, because many cruises actually involves multiple calling at ports, and the new passengers were coming on board, so they need to be made aware of what's happening and what they need to do to protect themselves. Next slide, please. So the very crucial elements, risk communication. So I will not dwell on to the details, because many of the health advice here already outlined in the previous slides, and also in Rosamund's presentation. I just wanted to mention here, we do regular monitoring on the information on the website, social media of the event organizers, seeing the event organizers and seeing the cruises. Sometimes we found very little information on the website. So here I really, encourage you to share that information with your prospective travelers and also your employees, and so they understand, what are the risks of the monkeypox. Again, all the precautionary measures and so on. And during voyage as well, and you have, if someone from the audience here, you actually also organize this type of themed voyages, so that you have the communication tools and also the channels, so you can continue with these efforts and include the post-travel as well. Next slide, please. Yeah, last but not the least, I wanted to highlight also the importance of using non-stigmatizing language. So our risk communication colleagues, and they have published a very, very useful documents. And here I just, make examples, because sometimes we are not the ones who dealing day to day, this aspect. Maybe inadvertently we might use the language that might, have the connotation of stigmatization and discrimination. So we need to really be very, very vigilant on this aspect. So I think this document provides a very important and very practical cues that you can use. So I just make the 2 examples here, but you have more examples in these documents. And so please, refer to that document if you are, you will be engaged on this risk communication efforts. So I think that, next slides are all the existing public health information resources in our website relating to monkeypox. So the last but not least, I just wanted to say that this is a learning process, not only for the non-health people, but also for the health professionals. So we're all together, learning together, take action together. So we really appreciate your continued cooperation and to support the public health response. So, to support our community's approach. Thank you very much. Thank you. Back to you, Sarah.
Thank you very much, Ninglan. So just before we move to the questions, I wanted to say that we, of course, will share with everybody who has joined us today the slides prepared by Ninglan and Rosamond, which contain the links to all the resources that they have referred to. We will also share the recording of this webinar with all those who have registered. So there have been a few questions about that, so not to worry, they will be shared. We had a few questions that came in over email, as well as a number of questions in the chat, or in the Q&A, sorry. So I'd like to jump straight in because I know Rosamond actually has to leave on the hour. So it would be good to answer some of these. We also have, as I said before, Andy and Vicky with us on the line, who will be answering questions as well. And I invite them also to review the Q&A and can type in some answers to these questions. An important one, I guess we'll start off with it, as it's been mentioned by a couple of folks in the Q&A, is the question about, is this a sexually transmitted disease? So we have a question saying, seeing there's the highest proportion of cases are among men who have sex with men, and the decrease in household transmission, even though it's spread primarily through contact, what are the reasons for not declaring monkeypox outbreak as sexually transmitted disease? So Rosamond, I think if you wanted to start with that, that would be great.
Sure. Thanks very much for the question. And it is certainly one that is on everyone's mind. Just to clarify a little bit, so WHO doesn't have any mechanism for declaring something to be a sexually transmitted disease or infection. And there are many diseases that transmit in different ways. So for example, scabies, which is a skin infestation by a parasite, can also be transmitted through sexual contact, but it is not referred to as a sexually transmitted infection. There are quite a number like that, including herpes may be referred to as an STI, but there are also other modes in which it transmits. So I think the important thing here is that monkeypox can transmit through a wide range of modes of transmission, most of which involve direct physical contact. That might include face-to-face, so that might include respiratory droplets or short-range aerosols, but it is not yet known precisely whether it is transmitted exclusively through semen, for example. So there's no question that skin-to-skin contact, and this includes mucous membrane contact, such as sex, whether it's anal sex or vaginal sex, clearly that constitutes skin-to-skin contact. So the question we're asking scientifically is, virus remnants, particles of DNA have been identified in semen, and some virus has been grown from semen. So it is entirely likely that this may be recognized as an STI in the near future. But at the moment, it's really hard to piece out the different bits of information to say whether this is a major mode of transmission or relatively minor mode of transmission, given that there's already such close skin-to-skin contact anyway. The reason this matters, and the reason that we're not really jumping on a new label for monkeypox, is also because of the assumptions that go with an STI. So the assumption is that a disease that's an infectious agent that's transmitted through semen or vaginal fluid can be prevented by condoms. That's the link that people make in their minds. STI equals condom equals no STI. This is not the case, right? So we do recommend condoms, partly as a precautionary principle, partly because we're now learning that there is a virus in the semen, but a condom alone may reduce risk, but it will absolutely not eliminate risk because you have contact with skin lesions that are on the body outside of the genitals. And so one of the reasons to not jump prematurely on the bandwagon of calling monkeypox as an STI is because we want to make sure that the modes of transmission are well understood and that a condom alone will not prevent the infection.
Thank you very much, Rosamond. And again, I invite Andy or Vicky or anyone who, if they would like to contribute to these answers to the questions, to just let me know. Turn on your video and let me know. That would be absolutely fine. Another question that has come through. Should a person with suspected monkeypox avoid contact with other animals? Is there this reverse transmission happening. Rosamund, is that something you'd like to take?
Sure. So there have been a small number of reports of domestic pets being infected in this outbreak. Those remain to be confirmed in the sense that in a case or two, the authors afterwards were not sure whether the pet actually had an infection, which means the virus in the body, as opposed to contamination of the skin and the fur because of the owner's infection. So this is a theoretical risk. It may be occurring in a very small number of cases. There was also just a study published of more than 40 persons with monkeypox who had over 100 and something pets, and none of those pets became infected. So whereas the risk is relatively low, theoretically possible at the moment, still relatively low, it is still recommended as a precaution to try and maintain some physical distance between a person who has monkeypox and their pets, because it is a risk. However, there's one other caveat. There was an outbreak caused by domestic pets in the United States of America in 2003, and those were prairie dogs who were infected through having been co-housed with other infected mammals from a different country. And so it is possible that animals can become infected. And so the other thing that we do ask, and this is important for the travel and tourism industry, is careful waste management. And I see Vicky's online, so maybe Vicky wants to jump in on waste management, because if bits of clothing, bandages, household waste are contaminated with monkeypox virus, the last thing we want it to do is get into a domestic, peri-domestic rodent population, rats or mice or field mice, because this is the species, a range of species that are particularly susceptible to monkeypox include rodents. And so we haven't seen that anywhere yet, but it's something we really don't want to see. So Vicky, maybe you want to help us out here with good waste management.
Hi, thank you, Rosamund. Can you guys hear me okay? Sorry, it's very early in the morning here in Canada, so I'm not quite prepared. But yeah, so in terms of waste management, what we are recommending is that any items that would be used by a person who has monkeypox or a person assisting somebody with monkeypox be carefully placed into a strong regular garbage bag in a non-healthcare setting. So if we're talking about a community setting or a hotel or cruise ship, wherever this person may end up being, that any materials that are used in the care of that patient or person be put into just a regular garbage bag very carefully and closed and sealed tightly, so somehow that the bag is closed and not left hanging open, and then basically it's disposed of in your normal waste management streams. We know that often in communities there is no particular stream available for what we would call isolation waste, which would generally be generated through a healthcare setting. So in community settings, waste that's being generated through households or general community areas, we just advise that you put it in a strong bag and dispose of it in the normal waste stream that you would use. So hopefully that's clear. Thank you.
Thanks, Vicky, and apologies for the really early start for you. But while we have you online, maybe you can just address another question that's come through. How high is the risk from surface contamination, such as on linens, high touch surfaces, for example, in hotels and holiday rentals? You're on mute.
Thank you. Sorry about that. So what we do know is in healthcare settings, we are seeing high contamination of the environmental surfaces where patients who have monkeypox are being cared for. And as such, we have specific cleaning and disinfection protocols in place in those settings. In community settings, in households, for example, where persons may live who have monkeypox, we also see high levels of contamination. But what that actually means in terms of whether it spreads to other people through that route is not entirely clear. We have seen some documentation in households where there has been additional cases where they live together, that there's been household spread, but whether that's through the contamination of the environment and linens, or whether through close contact as described by Rosamond, skin-to-skin contact is not entirely clear. So in these kinds of settings, I mean, ideally, if somebody is identified to have had monkeypox, we're recommending just routine cleaning and disinfection, what you would normally do for your household cleaning, and careful handling of linens. Don't shake them, that sort of thing, if you're actually caring for somebody or supporting somebody in their home with monkeypox. But otherwise, the linen should be handled carefully. You would send them to the laundry or take them to the laundry. Ideally, the person who has monkeypox can do that, and then wash it in hot water and soap, and then put it in the dryer. If you don't have hot water or soap, then you would just make sure you have a good detergent that's effective for cold water. And if you can put it in the sun or somewhere warm to dry, that would be better. In terms of the risk to workers in those settings who may be handling linens, it's not really clear. You may not know that the person has monkeypox. So again, just safe handling of linen, not shaking linen in general, is the best approach. And then just routine cleaning and disinfection policies at this point in time.
Thanks very much, Vicky. Yeah, there have been a couple of questions about that in the chat. So I think your answer has cleared that up for many. Andy, I saw that you were typing the answer to a question which I thought was quite important to address, and that was about different other occupations beyond the transport and tourism sector that might be at more need of attention, and maybe you wanted to actually speak to that right as well.
Thank you, Sarah. Hi, everybody. Thanks for the opportunity. I did answer in the chat, but happy to say more. At present, we're not really identifying, and I'll perhaps answer one of the other questions, which is why single out cruise themed cruises, because I think it's kind of linked. At the moment, we're not recognizing any particular work sector as requiring special attention in terms of how we're seeing the epidemic evolve. As Rosamond's slides showed, we're talking about most of the cases still being confined to men. Within that group of men, it is largely connected to the sexual networks of men who have sex with other men. And so it really is the social and sexual network that is the phenomena driving the epidemic, rather than the workplace occupation or sector. Having said that, sex work is work, and there are many sex workers in all countries. And we've been working very closely with the representatives from sex worker networks, because we've seen some examples of chains of transmissions that are linked to sex work, heterosexual sex, in previously affected countries. And if we look at what's happened with previous examples of diseases that can be transmitted through sexual contact, it's an area and a setting that we need to really be careful to sensitively work with the representatives there and make sure appropriate advice is available. So we've prioritized sex work. By extension to that, I think there are other professions that we actually mention in some of the guidance we have on sex work. So, for example, people who work in massage therapy may also be interested in following some of the same advice, because as we know, and I think as Rosamond and others have explained, really what facilitates transmission is that close, intimate contact. It doesn't have to be sexual contact, but it's the closeness of the physical contact that really helps with transmitting. Thanks, Sarah.
Thanks very much, Andy, and I think both you and Rosamond have to leave on the hour, so I'll be aware of that. But Rosamond, there have been a couple of questions about vaccination. One is, do we have any recommendations or guidance on vaccination? The question was particularly with regard to potentially employee accommodations. And the other is the smallpox vaccine for those that were vaccinated for smallpox a while ago. Is it still effective? So perhaps you could answer those two together. That would be great.
Sure, thanks. So anyone over the age of 40 or 50 may have been vaccinated against smallpox. It's entirely likely that you have, and you would find that by finding sometimes impressive, but sometimes also now waning scar on your shoulder. We don't know a lot. At the time, the vaccine was very powerful and it protected people for a long time against smallpox. It's actually the same vaccine. It's vaccinia virus-based. Smallpox and monkeypox vaccines are both made from another orthopox virus called vaccinia. We actually don't know now a lot about the remaining immunity, even for those who have this scar. And we are seeing cases of monkeypox in people over the age of 40, obviously, but also over the age of 50, 60, and even 70. So it's not likely to be absolute protection for everyone at this time anymore. And so it is not a contraindication to receiving another dose of vaccine. And it may boost, and another dose of vaccine may boost immunity for anyone who already has some immunity from smallpox vaccination. Regarding indications for vaccination, yes, there is a WHO guidance, interim guidance on vaccines and immunization for monkeypox. It's accessible on our WHO outbreak page, a monkeypox outbreak page, and it has been updated once, and it will be updated in the coming days. But essentially, the recommendations haven't changed much, and that's that the vaccine is recommended for people who are at high risk, and primarily that does mean men who have sex with men, but also others who may have multiple casual sexual partners. We've just been talking about risks that people may face if they are selling sex for either supplies, goods, or money. It's not simply the commercial sex industry. There may be other situations where people find that they don't have, easy access to control over their risk, but also at the same time, those same people may not have easy access to vaccine. So it's definitely a conundrum that those who are high risk are advised to consider vaccination. And it's a vaccine that has been developed precisely for the purpose of making it safer than the original smallpox vaccine. So we're not too concerned. We're always concerned about side effects of vaccines, of course, but they tend to be local side effects. There don't seem to be many major adverse events from this particular vaccine because the entire purpose of its design was to make it safer. However, the accessibility is still variable across countries and regions. And we do strongly recommend that you seek it out, that people seek it out before travel, not because they're traveling, but if they are at risk, right? So those at risk also travel, and this is the group that's indicated. For health workers and people who may be exposed regularly, either sexual health services, frontline healthcare, emergency rooms, or people who know that they're going to be taking care of patients with monkeypox. For them, vaccine is also recommended. For others, really it's a supply issue. It's not contraindicated, but at the moment, other groups may not fall into the high risk category and therefore would not necessarily be first in line for a vaccine. Thanks.
Thanks very much, Rosamond. And I'm aware you need to go, but Andy, is there anything you wanted to add or anything you wanted to pick up on the last questions before you head off?
I'm actually okay to stay a little longer, Sarah. So
Okay.
I don't have the hard stop that Rosamond has. Mine's in 1 hour, in half an hour, excuse me. So
Okay,
I'm happy
great.
to stay on. Yeah.
Thank you. Well, then quickly, Rosamond, before you go, one quick last question, which was quite interesting. Is the smallpox vaccine configured for animal health management, or is there any animal vaccine against animal monkeypox infection?
Oh, a great question. I don't think I've heard that before. No, I don't think the vaccine is indicated or developed or recommended for animals. It is, there are, as we've said earlier, many species of animals who are susceptible to orthopox viruses, and that includes cowpox, vaccinia, camelpox, monkeypox. There's a whole range of pox viruses that are enzootic in their respective host and reservoir animal groups. So pox viruses are ubiquitous, and smallpox was the human pox virus, and now monkeypox is looking like it wants to be the same thing. It wants to join that club. But for animals, I don't believe that there is a specific vaccine developed. And so I would not recommend using our monkeypox or smallpox vaccines for animal inoculation at this time.
Thanks very much, Rosamond, and thank you for your time. And yeah, good luck with the next meeting. So we'll stay on a couple more minutes. We have a number of questions. Vicky, I'm going to call on you. I think there are two questions that potentially you might be able to answer. The one is, do we have any knowledge on what the length of virus survival is on inanimate surfaces? And the second one was a question that came in over email, and that was with regards to swimming pools. What is the risk with the use of swimming pools? If someone is coming to swim, may they also infect others through that way? So over to you, Vicky.
Hi, thanks, Sarah. So actually, I was just answering that question. I was typing it in around the virus survival. So thanks for pointing that out. So we are finding studies are being done where they do swabs of the environment and they are able to detect monkeypox virus presence for, in some cases, up to 15 days. It could be longer. It really depends on the surface. It depends on, the severity of the illness of the person who is in the area, how much shedding they are having of skin or the virus itself. But just because we're finding the virus doesn't mean that it's actually able to be spread to other people through contact with those surfaces. So that's not entirely clear. So we may find it on some surfaces for up to 15 days. It could be longer on some fabric type surfaces. But again, exactly what that means in terms of being able to be spread to others isn't clear. So what we do recommend in the meantime is that if you are in an area where there is a person with monkeypox, for example, in your household, or something like that, that you do regular cleaning with household disinfectants are usually effective, and that there is a list on the FDA website where you can get lists of approved disinfectants that are effective against monkeypox. And in general, monkeypox is a virus that is very susceptible to chlorine. And this is important when we talk about pools. So first of all, public health advice is usually that anybody with a rash or open skin or open sores should never go into a public pool or spa setting. So that's for a number of reasons. Number one, to reduce risk of transmission of any types of viruses or bacteria. And also, if you have open sores or rashes, it can be very irritating and actually make them worse. So we do advise in general that people with rashes or open skin don't go into public pools. However, because monkeypox is quite susceptible to chlorine, what we do know is that in general, the chlorine that is used for routine pool disinfection is quite effective against the monkeypox virus. So the risk of transmission through public pools would be significantly low, if not none at all. Hopefully that's clear. Thanks.
Yeah, very much so. Thanks very much, Vicky. Ninglan, I'm going to call on you now. There was a question regarding, do we have any data on infections on cruise ships? So I wonder if you could potentially answer that. The second question that I thought maybe you'd like to speak to, which is a bit broader, which is a question from Punor, which says, is there a single platform dealing with real-time monitoring of multiple infectious diseases that emerge or re-emerge at the same time that may not be intersecting spatially? So maybe you can speak to some of the stuff that WHO has available on that aspect as well. Over to you, Ninglan.
Yeah, thanks very much, Sarah. Yes, for that, the first question, I think that's a very great question, and which we do not have the data for the themed cruises yet. So we are monitoring the organization of the themed cruises, and which have potential, seem related to this heightened at-risk groups, let's say. But we do not have the data in terms of the cases coming out from all these themed cruises. Which were, if we wanted to really, access to that data, which requires the surveillance reporting from the local health authorities, the health clinics, and so on, to include the information of travel, which is not always the cases. So that's also our, let's say, a little bit kind of a roadblock for accessing the accurate data in this aspect. Second question. Yeah, it's a difficult question. I think we do have the international health regulations. So as we touched upon in the very beginning of my presentation, we do have the national focal point mechanism, which provides the information based on Annex 2 of the International Health Regulations. There's a decision-making tool to make sure that the risk assessment has been made and to determine whether the health event will actually potentially constitute of public health of international spread concern, then which will be needed to share with the WHO, IHR, the International Health Regulation Secretariat. So this is the official mechanism. So I don't know if that's the the question that you want to answer, but I think that's what we operate in terms of how to monitor the disease in the country level. Thank you.
Thanks very much, Ninglan. And yes, we also, if you Google WHO emergency dashboard, there's also a dashboard there that does show what outbreaks are happening in the world and where. So that's another resource that can be used. Another question: are there any known long-term effects of monkeypox? I'm not sure who wants to take that. Andy, do you want to go?
Thanks, Sarah. There's so much that we're learning all the time about monkeypox, including, for example, if people have experienced infection. Unfortunately, in the context of the current outbreak, the large majority of people who do go on to contract monkeypox experience a relatively mild illness. And so generally after 3 weeks or 4 weeks, they're well again. We don't know if post-infection immunity is really effective, how long that lasts. And we also know that some people may go on to reinfect. But the question about long-term effects, I think for sure, when we look at the very severe cases, which are quite graphic, very painful, lots of scarring, I think for those individuals who are in a minority, absolutely there will be long-term considerations, including mental health considerations for those individuals. But for the majority, in the context of the current outbreak, it is relatively mild. But as I say, we're learning all the time. And so there may be data, well, there is data every day that's helping us better understand how this outbreak is also different to what we've seen before in previously affected countries. Thanks.
Thanks, Andy. Another one that was actually directed to Rosamond, but I wonder, Vicky, if you'd like to have a go. The question is, in one of the slides, you mentioned talking as a means of transmission. Can you clarify again what is defined as close contact? Is it 2 meters, more than 3 hours, etc.? So Vicky, I'm not sure if you wanted to address that.
Thanks. So I don't think we have a specific time in terms of close contact. What we are concerned about when we're talking about talking is the potential for there to be some sort of, if the person has oral lesions, or there could be droplets in their respiratory tract system that they could expel when they're close to somebody and they're talking. And so that's a risk there. In terms of the exact distance, I mean, we often define close contact in terms of less as 1 meter distance, but we also know that there's a spectrum for droplets versus how far they can spread, how tiny they are, and those kinds of things. I mean, we see this even with COVID, are always evolving. So right now, what we do refer to in terms of close contact is more that skin-to-skin contact, but we cannot rule out whether things like talking, where you may have oral lesions or some sort of respiratory tract involvement, and droplets could be spread. So it's that 1 meter or potentially more. But in terms of a time frame, we don't really have that defined for monkeypox.
Thanks, Vicky. Ninglan, one more question for you. I wonder whether WHO recommends any monkeypox screening, such as self-declaration for international travelers at airports.
Thank you. Thank you for the question. And no, we do not have a WHO recommendation for screening for this particular monkeypox. As the EC recommendation has, the outlined the major recommendation which are related to the cases and also the context. However, we know that everyone has a role to play in this monkeypox response. So, of course, that the health information and to encourage the travelers to seek the medical advice and or report to the Port Health Authority if they they are developing the monkeypox compatible kind of signs and symptoms, and knowing they might have these high risk activities associated with this discoveries, and then that are very much encouraged, but not the the mandatory screening at the airports at this moment. Thank you.
Thanks very much, Ninglan. So I think we're about to wrap up now. I'm just going to ask each of our panelists here if there is a specific question that's left over that they'd like to address, or at least some closing remarks, please do let me know. Vicky, is there anything final from you that you'd like to address or speak to?
I think just
and then you can go and get your coffee after that.
Yeah, thanks. No, I think this webinar has been great, and thanks for the opportunity to participate. And but I would say just that the information is evolving, and we are trying, to reevaluate the guidance that we are putting out and to make sure that it's current. So just to advise participants to continually keep checking back on the WHO website for any updates and new information as we learn more and more about this virus, and specifically on how it's transmitted and what kind of measures we can take in the community. Our initial focus has really been the healthcare, but for IPC, but we are working really closely right now on trying to get more guidance out for community settings. So to please check back on our website and keep tuned in for new information as it emerges. Thanks.
Great, thanks, Vicky. Ninglan, anything final that you'd like to address before we wrap up?
Thanks very much. Yeah. So I think also a similar line with Vicky. I think that with more and more we're learning, and there will be more information coming out. In terms of the international travel, because the EC, the Emergency Committee, will be convened in 2 weeks, around 20th of October. So there will be the new potentially revised recommendation, or the recommendation of the last committee, EC committee, will be maintained. So please stay tuned, and then you will see whether the recommendation will be changed or remain the same. Thank you.
Thanks, Ninglan. And Andy, I'm going to hand to you. And I wondered also if I can just put you on the spot a little bit, because as we've been speaking, the question around endemic countries and the data not being necessarily compatible with what is seen in endemic countries. Can you speak to that at all quickly before you have some?
Thank you, Sarah. I think several of these questions that are remaining unanswered are somewhat linked. I think we've had some evidence of human-to-human transmission in previously affected countries that has been facilitated through sexual contact, both heterosexual and male-to-male, for some years. But for different reasons, this hasn't necessarily always found its way into the literature. We are able to do some retrospective studies. We're learning more all the time, as other speakers have said. But I think it's correct. We are seeing a different profile for sure, probably more emphasis on household transmission as well in certain contexts. But I think we should also recognize that some countries are very difficult environments to acknowledge and to record and to talk about male-to-male sex as a phenomenon. And for many of those countries, we know from HIV that very often it's helpful for everybody concerned to be slightly broader and perhaps blurred in how things are described. I know this is perhaps counterintuitive to those of us who would like to be very clear about and factual, but this is a reality. It's very difficult to collect data on men who have sex with men, for example, in many contexts, including several of the previously affected countries. We're working closely with community groups in all contexts, previously and newly affected countries, including representatives from communities of men who have sex with men. So we're able to get some good anecdotal and qualitative data to also supplement what we're finding through the reported data sources. So I think that's one answer. And then I think there are a couple of other questions as well about deaths attributed to monkeypox. I think the 26 deaths are largely mixed. Usually the common denominator is some level of immune suppression. So people have got other issues going on, perhaps advanced HIV, perhaps cancer or chemotherapy treatment, etc. And the deaths are linked to numerous things, including encephalitis, etc. as well. So again, we're learning as we go, Sarah. So I know we're short of time, so I'll hand back to you.
No, thanks very much, Andy. And I think it's been a really informative webinar, and we're really grateful for those who've joined us today, who've shared their questions. And I'd like to personally thank Ningland, Vicky, yourself, Andy, and of course, Rosamond in her absence for being here and being open to this. And also, of course, Mary Paul, who is our interpreter. So thank you to all. As promised, I'll share the links to the recording as well as the slides that has all the resources on them. And we look forward to seeing you again shortly, I'm sure, on another event. So thank you, and I hope you all have a really good rest of the day.